Hello, everyone, and welcome to the Ramalinga Swami Center's colloquium series on equity and social determinants of health. Today's colloquium has been a long time in the planning with Dr. Subha Sri Balakrishnan, and I'm glad that we've persisted because I think she has some very interesting and important things to say about abortion in India. And it hit us a few months ago that we've not had anyone speak on this very important topic as part of our colloquium series, and the only person we wanted to invite to speak about that was Dr. Subha Sri. She's an obstetrician with an extensive experience of over 2 decades working with community organizations and health systems to improve women's health in India. And through her work for over a decade with the Rural Women's Social Education Center, RUSEC, a Dalit women's organization in Tamil Nadu, Dr. Subhasri has gained a deep understanding of the realities of gender, caste, and poverty and their role as key determinants of social determinants of women's health. She's used this experience to work on issues of sexual and reproductive health, maternal health, and safe abortion. She's also been involved in initiatives involving introducing gender in medical education, training healthcare providers and program managers in sexual and reproductive health and gender and health, and in training programs on gender-based violence. If it's something to do with women's health, Dr. Subhashri has had a role to play in it, for sure. She has played an important role in supporting public health systems, not just in Tamil Nadu, but in Bihar, strengthening comprehensive emergency obstetric care in the government hospitals there. She's worked as a senior technical officer in India for the Center for Maternal and Newborn Health, the Liverpool School of Tropical Medicine, and serves on working groups of the WHO and many other organizations. Her role currently is, she's a member of CommonHealth, a coalition that works on reproductive health and safe abortion issues across several states in India. We are very excited to have you here, Dr. Subhasri. Thank you so much for your presence here today. Quick reminder to all our listeners, if you have any questions, please put them in the Q&A box at the bottom of the screen, and we will be sure to pick them up for discussion at the end of Dr. Subhasri's talk. Thank you all for your attendance. Dr. Subhasri, the floor is yours.
Thank you very much, Abha. I hope you can hear me clearly. Yeah. Yes. So thank you very much for this introduction, and thank you very much also for including abortion as a topic. It is a topic that's often doesn't get the attention it should when we talk about women's health or reproductive health. So thank you very much for that. Let me just share my screen to pull up my slide. Just give me a second for that. Are you able to see my screen?
Yes, we can.
Yeah, in slideshow mode. Okay.
Yes.
I will not be able to see your hands or the chat box. So in case there's anything, please feel free to interrupt. So like Abha said, jumping in, the title of today's talk is actually the promise and the reality of abortion access in India. The work that I'll be presenting here is the collective work of CommonHealth, the coalition that I work with, and several of my colleagues have worked on some of the studies and reports that I'll be sharing with you today. So acknowledging their contribution to the talk that I'm going to be, the slides that I'll be sharing with you. Okay, so I wanted to start with a quote by someone called Loretta Ross, who's a reproductive justice activist from the United States. She says, when facing an unplanned pregnancy, if you have good answers to those human rights concerns like job security, educational opportunities, a decent place to raise your child, to house your child, to feed your child, then many people dealing with an unplanned pregnancy may turn that unplanned pregnancy into a child. But if you have bad answers to those human rights concerns, then that increases the likelihood of turning that unplanned pregnancy into an abortion. This quote actually captures very well the social determinants that actually kind of drive the need for abortion in case of an unplanned pregnancy, and the need for safe access to a safe abortion in such circumstances. Now, why do we talk about abortion? I just want to dwell a little bit on what the global data says. So every year, around 250 million women become pregnant. worldwide. This is globally, right? Now, out of these, almost half of these pregnancies are actually unintended pregnancies. So when we say unintended pregnancies, either the person did not want a pregnancy at all, or they did not want it at that particular time in their life. So about half of the pregnancies, 48%, are actually unintended pregnancies. Now, what happens to these unintended pregnancies? Now, 6 out of 10, so more than half, about 60% of these unintended pregnancies end in an induced abortion, which is the topic for today's conversation. Now, what is striking here is that nearly half of all these induced abortions are unsafe. Basically, when we say unsafe, we mean either they are um, uh, performed by providers who may not be trained or have adequate skills to do the procedure safely, or the procedure is done by methods or in a place where a safe provision of abortion is not possible. Now, the vast majority, almost all, one can say 97% of these unsafe abortions occur in developing countries. More than half of these occur in Asia. And if you look at Latin America and Africa, the majority of all abortions that take place there, approximately 3 out of every 4 abortions in Latin America and Africa are unsafe. So the burden of unsafe abortions actually is pretty big. Now, 1 in 4 who have an unsafe abortion are likely to suffer severe complications. And depending on the data source that you may refer to, because data on abortions is not easy to kind of collect and come by. Depending on the data source, about somewhere between 22,800 to 31,000 women die annually every year from unsafe abortion globally. So this is what the global data is. And therefore, safe access to safe abortion, or if the opposite corollary of unsafe abortion, if you look at it from a public health perspective, is a big burden that needs to be talked about. Now, that is one perspective to look at it from, public health perspective, but there are also other frameworks that one can look at it from, and we'll be talking about some of it today. Now, in today's talk, what we will look at is the legal scenario in India. We will look at some data on abortion from India itself, or from the country. I talked about the public health framework, but what would a human rights framework to abortion actually entail? What would it mean? What are some of the barriers to accessing safe abortion? And then finally, I want to talk about some emerging challenges that we are facing in this area of access to safe abortion over the last few years, that have kind of started coming up over the last few years. And finally, placing abortion as an issue of reproductive justice. Okay, so jumping in, first I wanted to just kind of clarify the law, what the law on abortion currently is in India. So if you look at the Indian legal scenario, most of us know that abortion is considered legal in India since 1971, when the Medical Termination of Pregnancy Act was passed, the MTP Act was passed. But what many of us don't realize is the MTP Act does not give a blanket kind of approval for all abortions. It is only an exception to a criminal law which exists from colonial times. So IPC sections 312 to 314 actually criminalize abortion, both the person who performs an abortion or the person who actually undergoes an abortion. So, so this law still exists. The IPC, the Indian Penal Code, is now the Bharatiya Nyaya Sanhita, and the sections have changed, but the same law still kind of remains in the BNS also. Now, this criminal law makes abortion a crime in this country. And what the MTP Act does, and what they did in 1971, was basically to provide a few exceptions. So if the abortion is carried under the conditions that are specified in the MTP Act, then that would not fall under the purview of the criminal law. So the MTP Act basically provides an exception to an existing criminal law. The other thing that I wanted to kind of underline here, that in India, the law does not make abortion access a right. So it is not considered a right of a pregnant person to actually go and seek abortion in the country. What it does is that the MTP Act specifies certain conditions which a medical provider, a doctor, has to have a medical opinion that the person fits under the conditions that are there under the MTP Act. And only if the pregnant person fits within what the law allows, the medical provider decides that the abortion can be performed. So the law is provider centric. It does not put the woman or the pregnant person at the center of the abortion decision making. And abortion is definitely not a right under the Indian law currently. Now, going into some details of the MTP Act. Now, the MTP Act, like I said, there is a criminal law. Now, the MTP Act says that if the abortion is performed, it specifies where, when, by who, and why. Okay, if these are kind of fulfilled, then the abortion will not come under the criminal law. It will be seen as an exception to the criminal law. So who can perform an abortion? So the MTP Act says a trained provider. Now this trained provider has to be a registered medical practitioner. So under the law, only an allopathic doctor, and someone holding an MBBS degree with additional training as specified under the law, which is very clearly detailed in the law, can actually provide termination of pregnancy services. What this means is that anybody other than an MBBS doctor is not allowed under the Indian law to provide abortion services. So nurses, ANMs, Ayush doctors, none of these providers are allowed legally to provide MTP services. Now, the law also says that this should happen in an approved health facility, and it gives details of how the approval process, etc., should be. Now, the MTP Act allows abortions up to 20 weeks of pregnancy, and since 2021, when an amendment to the MTP Act has been in place, it extends the period of the gestational age up to 24 weeks for some specific circumstances, and I'll show you what those circumstances are in the next slide. So up to 20 weeks, and under certain specific circumstances, up to 24 weeks of pregnancy, the MTP Act allows abortions to take place. Now, I just want to digress a little bit here and to bring in the PCPNDT Act, which is the Preconception Prenatal Diagnostic Techniques Act, which is the act that makes sex determination illegal. Now, there is a lot of conflation, people bringing in the MTP Act and the PCPNDT Act together, and a lot of confusion on the ground about whether sex selection is illegal, whether sex selective abortion is illegal. Please note that the PCPNDT Act does not talk about abortion. It only talks about sex determination, and very clearly says the act of sex determination is illegal. Now, whether a person continues the pregnancy after the act of sex determination or chooses to undergo a termination of that pregnancy after the act of sex determination, the PCPNDT Act does not get into that. It only talks about sex determination. At the point of sex determination, the law says that is illegal, that is unlawful. Okay, so this is the MTP Act. Now, what are the circumstances under which abortion can be provided under the MTP Act? Up to 20 weeks, under the advice of one registered medical practitioner. So one medical provider can decide that the conditions under the MTP Act, specific conditions, have been met. What are these conditions? If the continuation of pregnancy poses a risk to the life of the pregnant woman, if the pregnancy, if continued, will result in grave injury to the physical and mental health of the pregnant woman, if the pregnancy is caused either due to rape or due to failure of a device or method of contraception. So these are considered as causing grave mental injury to the pregnant woman, and therefore seen as a ground for terminating the pregnancy. And the last is the existence of substantial risk that if the child is born, it would suffer serious physical or mental abnormality. So up to 20 weeks, one registered medical practitioner can decide that if any of these conditions are kind of, seen to be the seen to underlie that particular kind of need for abortion, then the abortion can be provided. Now, what the amendment in 2021 did is that it extended this period up to 24 weeks and for a few specific circumstances. Now, for between 20 to 24 weeks, this needs to be decided by two registered medical practitioners. So two doctors have to sign off and say that these conditions have been met. Okay, and who are the specific groups for whom this is allowed? So survivors of sexual assault or rape or incest, minors, if there has been a change of marital status during the ongoing pregnancy. So, for example, if the male partner, the husband has died leading to widowhood, or if there is a divorce, women with physical disabilities, mentally ill women, they include mental retardation also within this. This is actually taken verbatim from the rules of the Act. Fetal malformation that has substantial risk of being incompatible with life, or if the child is born, it may suffer from such physical or mental abnormalities to be seriously handicapped. And finally, women with pregnancy in humanitarian settings or disaster or emergency situations as decided and declared by the government. So basically, if you look at it, these are basically persons who are facing specific vulnerabilities, who may not be able to access abortion services before 20 weeks, and therefore the law kind of extends the period up to 24 weeks for these. But since it is abortion slightly later in the gestation, I mean, that seems to be the thought process behind the law, that there needs to be two medical practitioners who concur that this abortion can be done for these specific reasons. Now, what happens beyond 24 weeks? If a person, what does the law say? So beyond 24 weeks, Section 5 of the Act says that if the medical practitioner is of the opinion formed in good faith, that the termination is immediately necessary to save the life of the pregnant person, then this abortion can be done. Okay, this is Section 5 of the Act. So if there is a life-threatening condition and the medical provider says that they invoke Section 5 in order to save the life of the pregnant woman, and that abortion is immediately necessary, then this can be done. This is what the law says. There is also another provision in the amendments that came in 2021, which says that if the fetus is found to have substantial abnormalities, now with the advancement in medical technology, very often fetal abnormalities are picked up even at a later stage in pregnancy. So if an abnormality is picked up, say, beyond 24 weeks, then a medical board constituted at the state level would actually look at the details of that particular case, and they may decide, the medical board will decide whether to allow or deny termination of pregnancy beyond 24 weeks. This is specifically for major fetal abnormalities that may be found uh, later on in pregnancy. So this is the scenario beyond 24 weeks. Now, I just want to add one more thing before I kind of summarize the legal scenario. So there was a Supreme Court judgment in 2022. I'm not going to the details of the case, but beyond the kind of, the specific kind of requirements of the case, the court went and made kind of larger kind of, statements around abortion itself. And importantly and very significantly, the Supreme Court emphasized that the right to decisional autonomy in matters of reproduction. So basically, it held that it is a woman alone who has the right over her body and is the ultimate decision maker on the question of whether she wants to undergo an abortion. So this was seen as something that was, very clear and, very clearly laying out that the right to decision autonomy of the pregnant person when it comes to abortion. It also said that unmarried, based on marital status, the law cannot exclude women from seeking abortion services, because then it would violate the right to equality. So basically, it permitted abortion for unmarried women on the same status as married women for all the kind of criteria that are there in the within MTP Act. And finally, this judgment, it also said, I mean, all of you would be aware of the discussions around marital rape in this country. Marital rape within marriage is not a crime. So it is deemed that a husband cannot be seen to have raped his wife, even if sexual act within marriage is non-consensual. But this judgment said, for the purposes of the MTP Act alone, for the limited purposes of the MTP Act, if a woman alleges that she was raped by her husband, then she would be entitled to abortion, though it did not touch the marital rape question at all. So it does not criminalize marital rape, but it says that for the purposes of giving an services of an abortion under the MTP Act, rape can be considered even within marriage. So these were some significant points made in this judgment in 2022. We will look at some of the emerging challenges from the legal side also, and with the courts and judiciary. somewhat later on today, but I just wanted to place this judgment also here. So therefore, if we wanted to summarize the legal scenario in India, basically women cannot access abortion on request. It is not a right. So it is not the woman who decides whether she needs an abortion. Ultimately, the decision depends on one or more doctors, depending on the conditions and the gestational age, agreeing that the grounds under the law are satisfied. So in that sense, it is a provider-centric law. It is not a right. It is not a woman-centric or a pregnant person-centric law. Abortion is still a crime with exceptions provided under the MTP Act. So if somebody does not comply with the requirements of the law, then it can lead to criminal invoking of the IPC and criminal prosecution for both the RMP, the registered medical practitioner, and the pregnant. Now, please note here that there is the law does not say that a registered medical practitioner is bound to provide services of abortion. If a pregnant person seeks an abortion service and fits under the clauses of the MTP Act, the registered medical practitioner does not have is not bound to actually provide that abortion service. They do not face any consequence under the law for denying the abortion. Okay, but on the other hand, if they do choose to provide the abortion, they then they open themselves up to the criminal law being invoked if something kind of is not seen to be fitting under the MTP Act. So there is actually a disincentive to registered medical to doctors to actually provide abortion services, and the law actually incentivizes the fact that you can deny abortion services. Why would you take a risk and provide abortion services if it can actually lead to problems? And by denying, you really do not face any consequences. So that is the current legal scenario in India. Okay, so I'm just now moving on we looked at data from the world on how many abortions take place globally in a year, but how many abortions actually take place in India. And for very long, we just had the kind of, small studies and we're projecting based on small studies. The most kind of what shall I say, robust data that we seem to have is from a study that was published in 2018 in Lancet Global Health, a study done in 2015. I'm not going to the details of the study, except to say that it was a survey of about 4,000 facilities across 6 states in the country, public and private. And also, it looked at sales and distribution data of medical abortion pills and basically arrived at estimates based on this data. Now, according to this study, it estimated that about 15.6 million abortions, that is around 1.5 crore abortions, took place in India in 1 year, in the year of the study, which is 2015. So it gives us an estimate that in a year, about 1.5 crore abortions take place in the country. I just want to show you this kind of this slide from which is taken from the study itself. Just to kind of, show a few details about where and how these abortions are taking place. Now, if you look at the bar graph on the left, so out of the 15.6 million induced abortions that the study kind of estimated, it estimates that surgical abortions, that is abortions that take place using some surgical method, are only about 14%. Okay, so the vast majority of abortions, the green part of the bar graph, are by medical abortions, are by using medication. So 81% of all abortions were medication abortions, and only a small proportion of abortions were surgical abortions. There is still a very small proportion of about 5% which are using other methods, probably traditional methods, probably unsafe methods, we do not know. Now, so that's the first point, that the vast majority of abortions that take place in the country are through medical methods. Now, if you come to the pie charts, the circles on the right, the top circle, which is a blue circle, is actually talking about the surgical abortion. So this 14% surgical abortions, which is about 2.2 million surgical abortions. If you look at where these abortions are taking place, you see that 25% of these take place in public facilities, but 75% of these take place in private facilities. Okay? So this is about surgical abortion. So the vast majority of surgical abortions take place in private facilities. Now, if you look at the The green figure below, which is the medical abortion. So the vast majority, which is 81% of all abortions are medical abortions. Now, where do these abortions take place? Now, if you look here, the picture is even starker. So only 2% of these medical abortions take place within public facilities and only 7% within private facilities. 91% of these, okay, so a huge proportion of these medical abortions actually take place outside of facilities, which means that women or the pregnant person who's seeking the abortion is either getting the medical abortion pill either after getting a prescription from a doctor and then using it outside of a health facility, most likely in their home, or it could be that they are also buying it over the counter, though that is not allowed in the country as of now. Medical abortion pills are under Schedule H of the Drugs and Cosmetics Act, which means that you need a prescription to get the medical abortion pills according to law. But people are still able to get it over the counter and therefore maybe buying it over the counter and then using it at home. So what this shows is that public facilities, the public sector facilities play a very, very small role in the provision of abortion services. And we'll see later on as to why this may be so. And people seem to prefer to go to private facilities for abortion services. And with the advent of medical abortion in the recent years, vast majority seem to be, using medical abortion outside of health facilities. And that seems to be the big bulk of abortions that are taking place in the country. Okay, now why do women seek abortion? What does evidence say? What do different studies say as to what are the reasons why women or pregnant persons may actually seek an abortion? If you remember the first slide that we talked about the what Loretta Ross said about having access to the different social determinants that actually enable you to give birth to a child and kind of take that forward. And if you do not have access to those, then you may not want to continue with that pregnancy. So unwanted pregnancy, and if you have an unwanted pregnancy, ending up with an unsafe abortion are both gender issues. Now, why do we say that? Studies have shown that women have very poor negotiating powers around their sexual and reproductive lives. Non-consensual sex is very common even within marriage. So there are several studies that talk about sexual violence within marriage and then also outside of marriage. So women have very poor negotiating powers. So around when to have sex, around the use of contraception, and then finally, if they're not able to use contraception or do not have control over when to whether and when to have sex, then ending up with an unplanned pregnancy and then needing an abortion. There is also poor access to contraceptives. So this could mean either irregular supply of contraceptives. So you may be started on a method, but may not have regular access to the method. You may not have access to the most appropriate method for you. You may not have adequate information about how to use a method correctly and safely. So all of these are, factors that lead to an unwanted pregnancy and then, push a person to seek an abortion, often unsafe. There's a lot of lack of awareness related of matters related to sexuality and reproduction. This is especially true of young people. There are several studies that show that young people are not aware, do not have basic knowledge about, about sexual health, and very often believe that, a single sexual act cannot result in pregnancy, or do not have knowledge regarding use of contraceptives, etc. Now, other causes include economic difficulties. Often, you may have a smaller child, you're in the middle of financial difficulties and do not want another pregnancy. Contraceptive failure is another reason. Concerns about the woman's health itself, and fetal anomalies that are discovered during a pregnancy. So what started off as a wanted pregnancy may become an unwanted pregnancy because circumstances change during the pregnancy. Now, I just want to kind of step back and reflect a little bit here on the unique nature of abortion services. Abortion services are distinct from almost all other medical services. Now, why is that? One, because legal stipulations guide them. There are very few medical services which have laws governing them. You do not have a law which says who should get an appendectomy, when they should get an appendicectomy, who should be performing it, where it should be performed. You do not have a law which talks about, say, hysterectomy, which is, such, I mean, the removal of the uterus, which is such a, big problem that we seem to be facing today. We do not have laws governing these procedures, but we have a law governing abortion. So that is something that makes it unique. The second is that the service need in terms of an abortion is time sensitive. Why is that? Because when you're faced with an unwanted pregnancy, you cannot wait forever for you to get that service, because the later the gestation, it becomes more difficult to access abortion services, both legally and medically. And therefore, the services are needed as soon as possible. So they're time sensitive. They're also not a chronic health condition. They're episodic in nature. So this again makes it unique and distinct. And the third is that these are gender specific. Abortion is needed only by women and persons who have a uterus and can get pregnant. So one half of the gender does not need these services, and only those who can get pregnant actually need these services. So it's a gender specific service, and therefore it is again quite unique and distinct. Now, abortion, because of all of these reasons, abortion seeking and service provision goes beyond it being just a medical issue or a technical issue, and brings with it a lot of other ramifications. So, moral, ethical, economic, political, legal, so it spans a whole range of these issues, and that makes abortion services unique. Now, if one way to look at abortion from a human rights kind of perspective, I talked right at the beginning about a public health perspective, how unsafe abortion is a huge problem, is a big problem, and therefore, from a public health perspective, it is something that needs to be addressed. But another way to look at abortion would be to look at it from a human rights perspective. What are the different human rights that would actually underpin the need for access to safe abortion? So first and foremost, right to life. Now, when I say right to life, and as related to abortion, the first kind of, or very often it is seen as, I mean, a lot of discussions center around the right, the fetus as having, life. And, so what I mean here is the right to life of the woman herself or the pregnant person themselves. This is because abortion can be, and in many times is, a life-saving procedure, not just medically life-saving, but in the circumstances that a person is in, abortion can be a life-saving procedure, and therefore access to safe abortion is very keenly pinned on right to life. And from a very similar kind of reasoning on right to health. So both of these form a great underpinning for access to safe abortion. Because abortion is gender specific, only certain genders need abortion services. Not providing abortion services is actually discriminatory to them. So the right to non-discrimination and equality also comes in here. The right to freedom from torture and cruel, inhuman, and degrading treatment. Being forced to continue an unwanted pregnancy and being forced to become a mother when one does not want it is actually seen as cruel and inhuman and akin to torture. So therefore, access to safe abortion is again, falls under this right. The right to privacy, to be able to take decisions about one's own private life, and to be able to decide what happens in one's own private life. The right to determine the number and spacing of one's children. The right to the benefits of scientific progress. So medical advancements make abortion a very safe medical procedure, and therefore, if one needs an abortion, and it is a right to be able to access it safely, to be able to access the benefits of scientific progress. So these are the various human rights. I'm sure we can talk about a few more too if we wanted to, but these are some of the human rights that underpin the need for safe abortion. Now, all of these, if you look at it from a human rights perspective and from a legal perspective, we often talk about choice. right? So the right to choice of a person to be able to decide what happens to them, to right to bodily autonomy, right to be able to decide what happens to their body. But it is often not just about choice, but it is also about access. Now, mainstream movements are focused on keeping abortion legal as an individual choice. Now, that's absolutely necessary, but it is not enough. Because even when abortion is legal, like it is in our country, under the very specific conditions under the MPP Act, many people who become pregnant cannot afford it, or cannot access it, cannot travel to the nearest clinic to access it, or for various reasons are not able to access it. So when there is no access, there really is no choice. The choice is meaningless, right? So we also need to talk not just about choice, but also about access. And on that note, I want to move to the next section, which is about barriers. So this is based on studies from our own experiences of working on the ground on what the barriers to access safe abortion are. And I'll be kind of speaking at it at different levels, speaking about it at different levels, at the individual level, family level, at the health system level, etc. Now, at the individual level, what are the factors that act as barriers to accessing safe abortion services? Now, first of all, like I said, lack of awareness itself. Now, lack of awareness of pregnancy, especially if it's a young person who's pregnant for the first time or does not have adequate information about it, but also lack of awareness of the law itself. Now, studies have shown that more than 80% of women are unaware that abortion is legal in this country. And this is also a factor of the campaign against sex selective abortion, where the PCPNDT Act, that sex determination is illegal, is has made is a very widely kind of publicized kind of idea, and therefore that is, and often there is a lot of conflation there between sex determination and sex selective abortion itself. And therefore, there is this idea spread that abortion itself is illegal. So most women are unaware that abortion is legal in this country. Even if they know, they do not know where to access where services are available or what their own entitlements regarding abortion are. The second is lack of autonomy. Like we said, women have limited power or control on decision making or on accessing services. They are not often the decision makers on whether a pregnancy should be continued or not, and that then acts as a barrier to accessing safe abortion services, even if one is faced with an unwanted pregnancy. Then lack of resources, poor access to modes of communication and information, transport, money. Money is especially important because, like we saw, most of the abortions are happening in private facilities. But even in public facilities, there are costs involved, which could be in the form of indirect costs or informal payments. So it is not something that is free, and therefore access to resources is something that is an important factor at the individual level. Then there are perceptions about health services which make people hesitate to seek health services, that the services can be disrespectful, that the providers are judgmental, that confidentiality may not be maintained. Confidentiality is because there is a lot of stigma around abortion. Confidentiality is something that is something that is very keenly kind of sought for when seeking an abortion service. That it may be expensive. Then the fact that there is often coercion for contraception under the family planning program, that providers are forced to asked to meet targets, and therefore coerce those who seek abortion services to have to adopt some form of contraception, often a long-term form of contraception, either an IUCD or sterilization, and that is again something that is a deterrent. And then shame and stigma. There's a lot of beliefs about morality, about sin. Um, uh, are you able to disclose to your family or some support person whose support you may need? Are you able to disclose? And if you're not able to, then delays in those disclosure and decision to seek abortion. So all of these act as barriers at the individual level. And this is especially true among women and pregnant persons from vulnerable communities. So either younger people, adolescents, those who may not have good levels of education, those who are poor, those who come from rural remote areas, who may not be in a marital relationship. So somebody who's single or who has multiple, already has multiple children. Those from minority religions who already face discrimination and therefore face even more kind of stigma and shame when accessing a sensitive service like abortion. Those with different gender identities, those women living with HIV, those who are in transactional partnerships, sex work maybe. So these women who are already in vulnerable situations. For them, these barriers are actually compounded even more. Now, what are the barriers at family level? In Indian society, there is a lot of pressure to prove fertility as soon as one is married, So early childbearing is what is expected. So in such a situation, if one does not want to kind of, even have that, have a pregnancy so early, even within marriage, there is a lot of pressure from the family to continue the pregnancy, and that acts as a deterrent. And it's not just to prove fertility and bear a child, but to bear a male child, which then becomes a factor in sex determination. There is all of this leads to lack of social support, emotional support, financial support. There is also fear of post contraception, and if that does not kind of meet what the person wants in terms of their desired family size, then that acts as a factor, as a barrier. Then there are also a lot of misperceptions that abortions will lead to, promiscuity, that it can lead to infertility, which are not based on scientific facts, but there are these misperceptions which also act as barriers. Now, at the community level, patriarchal social norms. Okay, so there are cultural expectations placed on childbearing. There is a lot of primacy given to motherhood in society. Um, some any sexual activity that happens outside the purview of marriage is seen as unacceptable. So adolescent sexuality is unacceptable, premarital sex is unacceptable. So any pregnancy that results from what is considered as unacceptable sexual activity is then there is a lot of stigma around that, and that acts as a barrier. um, Again, lack of awareness about legality, about services. Now, studies have shown that if you actually went to communities and asked their views about whether abortion is okay or not, you will find a whole range of views. So from that it should be allowed in certain circumstances for certain people, to all the way up to abortion is a sin. So there is a whole range of views about abortion. And again, stigma, like we spoke about, especially for those who are in socially unsanctioned relationships. And also misperceptions in the community about complications, infertility, and so on and so forth. So now these are all the barriers that are there at, say, individual, family, or community level. But there is a lot of barriers that happens at the health system level. And if as people working in the area of public health or advocating for safe abortion services from the health system, this is an area that requires a lot of engagement and intervention in. And what are these factors at the health system level? Now, so number one, unavailability. So this could be unavailability of infrastructure, of supplies, of equipment, of trained service providers. So a facility may be approved and recognized. Government facilities are all deemed to be approved, and you may not have trained service providers in many of these facilities. Even when there are providers and infrastructure, supplies, etc., available, studies have shown that providers can be extremely hostile in their behavior to somebody who's seeking an abortion. They can often be judgmental. They can be coercive in terms of pushing for the person to have a long acting method of contraception. So this acts as a major barrier for persons to seek abortion services. There is also a lot of denial of services that takes place because of what is claimed to be personal beliefs. So providers' own personal beliefs about the moral, ethical kind of aspects of abortion. And like I said earlier, the law does not talk about this at all. It does not penalize a registered medical practitioner for denying an abortion. People, providers can invoke their own personal beliefs in denying an abortion, and that is something that happens quite frequently. All of this is also underpinned because of the fact that the medical curriculum itself does not talk about any of this. Okay, so topics like, say, gender, patriarchy, misogyny, sexuality, discrimination are not things that are taught in the medical curriculum, and concepts like rights or choice are very cursorily covered. So when a young doctor actually comes out of medical school, they do not have any kind of sense of any of these issues, and why abortion should be a right or a choice, or why safe abortion access is something that should be seen as a human right. These are not why abortion is a gendered issue. These are not something that a young medical doctor is trained in, and these are the people who are expected to provide abortion services. So the medical curriculum does not actually match what is expected of them in terms of services. And finally, we saw that a vast proportion of abortions take place in the private sector, which is because the public sector is seen as something that where providers often deny abortion services, where confidentiality is not maintained. So women's needs are around, seeking an abortion service are often perceived as not being met by the public sector, and therefore um, they reach out to a private sector. But the private sector is unregulated, hugely exploitative. There are exorbitant costs, and the costs actually vary based on the gestation age. So the later in pregnancy that you seek an abortion, the much higher the cost, and based on the desperation of the person seeking the abortion. So if a person is, say, um, um, is not in a marital relationship and needs an abortion service, then the costs are much higher. So the private sector actually is a very exploitative kind of scenario there when it comes to abortion services. Finally, at the policy or program level, there are lots of gaps in program design and implementation. For example, if one way to look at the family planning, that basically provides contraceptive services only for married couples. The eligible couple that is defined under the family planning program is a heterosexual married couple. And therefore, anyone else who needs contraception service is actually excluded, left out of the program. And that is a huge gap in the program design itself. Then we all know that the family planning program sets targets, though it's supposed to be a target-free approach. On the ground, there are always, targets that are set, which leads then to coercive, when it comes to contraception services. Abortion is not seen as an essential service. During the pandemic, we saw that in the list of essential services that were to be provided during COVID, abortion was not initially listed, and it took a lot of effort and advocacy to actually bring it onto the list of essential services. When we have already seen that actually abortion is a very time-sensitive service, so you cannot wait for even a couple of weeks if you need an abortion, because every single week adds to the complexity of receiving the abortion service legally, medically, in all ways. And therefore, the time sensitive nature of it makes it very unique, but it is not often seen as a service that is essential. And finally, there are several other policies and programs that have a collateral impact. The two-child norm, the legal age at marriage, the PCPNDT Act, we talked a little bit about it. POCSO, which criminalizes any sexual activity below the age of 18 and therefore makes mandatory reporting of any sexual activity below the age of 18, acts as a huge deterrent for people to actually access safe abortion services. Which this is kind of completely in contradiction to the RKSK program, the Kishore Swasthya Karyakram, Rashtriya Kishore Swasthya Karyakram, which talks about contraceptive access for younger people, adolescents and young people. So there is a lot of contradictions even within policies and programs and laws, which then all of which have an impact on abortion. Okay. Now, having said all of this, I just want to focus here on some emerging issues that we are seeing over the last years, and I'm drawing heavily from the work of my colleagues in CommonHealth, some of whom I saw have also joined this Zoom call today. Now, the first issue I want to talk about is the emergence of anti-choice movements. Now, we all know that in 2022 in the United States, the Roe versus Wade, the law was overturned. Basically, it provided federal protection to abortion. And what this did was that each of the states was free to, to legislate on abortion any which way they wanted. And there was no, the federal protection was removed. And this resulted in the states, in several states, especially conservative states, actually passing very, very stringent restrictions on abortion. Some states even stipulating that, any abortion at after the fetal heartbeat is kind of, seen, which is around 6 weeks, which is by the time the person realizes that they're pregnant, would be kind of, criminal. And they've criminalized, either seeking abortion or providing abortion. So there's been a lot of churning in the US, and those of you who've been following this news, following the news around abortion, would have seen this. But what this has done outside of the United States is that it has sparked similar anti-choice movements all over the world, and that is the concern. So my colleagues in CommonHealth actually did a mapping of these anti-choice movements in the country, and there were some very, very interesting and concerning kind of findings that came up. Now, who are these entities who are actually spearheading these anti-choice movements? So many of these include faith-based entities, so Catholic entities, but not just Christian entities, also Hindu religious entities. And then not just faith-based entities, but also NGOs specific NGOs who are spearheading these anti-choice movements. They draw inspiration and support from international networks and also funding. Now, I just want to pause here and say I'm using the word anti-choice very, 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 I'm not using the word pro-life as most people use. Because even those who talk about access to safe abortion, we are also pro-life. We are pro the life of the woman. So we are pro the choice of the person. So the person who's talking anti-abortion is actually anti-choice. If they are in no way pro-life. So this is a very deliberate choice in terminology that we're making. So these are anti-choice movements. Now, these anti-choice movements actually target groups. Very concerningly, they target young people and women, and specifically very young. So school students, teenagers, young adults, they kind of, have extensive educational outreach initiatives, seminars, workshops, courses, which are centered around anti-choice ideologies in schools and colleges. And this is something that is really concerning, influencing the kind of, the perceptions of young people. Now, what is again interesting is that they do not stop just with abortion. This condemnation and this anti kind of reproductive choice extends to other aspects of sexual and reproductive choice. So they denounce same-sex relationships. They denounce premarital sex, contraception use. They advocate for traditional values like abstinence and the sanctity of marriage. So there is a whole range of anti-reproductive choice. So this is not just against abortion, but largely against reproductive rights themselves, sexual and reproductive rights. The other key thing that as a strategy that these entities seem to use is that instead of putting the woman or the pregnant person at the center of the discourse, they put the fetus at the center of the discourse. So they take a life from conception position, that life starts from conception, and therefore talk about the right to life of the fetus. Now, I want to point out here that under international human rights law framework, the legal frameworks, human rights are seen to be vested to a person at the point of birth. So the moment you're born, you have human rights, not before that. So this whole right to life of the fetus itself is actually something that is not recognized in international human rights law, and therefore this life from conception position becomes very problematic. And by doing this, they actually appropriate the human rights narrative in kind of making an anti-choice. So they're anti-reproductive rights, anti-sexual rights, but they adopt a human rights kind of position. So it's a kind of a false equivalence. Again, strategically, many of these people have positioned themselves within campaigns against sex selective abortion. So they may start off as kind of, opposing sex determination and sex selective abortion. But if you look at the discourse, it is actually not just against sex selective abortion, but against all abortions. So again, there is a appropriation of the campaigns against sex selective abortions to bring in an anti-choice kind of discourse. These groups are actually asking for the repealing of the MTP Act. So they are opposed to the MTP Act and see it as an act that kind of, condones, taking away of a life or, even murder. And so therefore, they have been organizing March for Life rallies every year on the anniversary of the passing of the MTP Act. And these are attended by young people, by anti-choice doctors, gynecologists, by people who are leaders, faith-based leaders. And get a lot of visibility in social media also. So this is something that is very concerning, and I would request all of you to read this report that is on these anti-choice movements. It's actually a very revealing kind of report on the dangers of this anti-choice movement. So this is one challenge that we are seeing over the last few years that seems to have gained a lot of ground in India. Now, the second challenge that I want to kind of, point out is we talked a lot about the law, but but we are seeing more and more an increasingly hostile legal environment when it comes to abortion. Now, why do I say this? Now, I want to just I'm not going to quote specific cases, but just to kind of, draw on a few themes that we seem to be seeing to be emerging. So there are contradictory judgments in very similar cases. So very similar kind of, background to the case, but different courts, different judges give contradictory judgments and from very different interpretations of the circumstances of the case itself. So that is something that we're seeing. We talked about medical boards, which are often asked to recommend whether abortion can be allowed or denied, especially in late-term abortion, so beyond 24 weeks. Now, medical boards, again, are inconsistent. They do not have standard kind of, criteria to say. So depending on who's on the medical board and what their kind of, personal beliefs are, there are inconsistent recommendations by medical boards. Now, even if there are medical board decisions, courts sometimes actually deviate from the medical board decision. So we have had instances of the court saying, telling the medical board to reconvene and relook at the case because they felt that some aspects were not kind of, addressed by the medical board, and the medical board kind of going back, which had earlier said that abortion may be allowed, going back and relooking at it and coming back and saying no, abortion cannot be allowed. So court decisions actually kind of, diverging from medical board decisions. We also see judgments which are based on technically incorrect premises. So, for example, late abortions are considered unsafe, whereas with medical advancement, abortions even in in later pregnancy are very safe if carried out by trained providers under good medical facilities, in good medical facilities. So, but these are seen as unsafe, and therefore, abortion is denied. Or if in late abortions, the possibility of the fetus being born live is cited as a justification for denying abortion, though there are medical guidelines which specifically talk about how to handle that situation and how to prevent the possibility of the fetus being born live. So these technically unsound kind of premises, which then kind of underpin some judgments. There are also more recently judgments that refer to the viability of the fetus or use the language of fetal rights. Like I said earlier, international human rights law does not recognize fetal rights, but judgments seem to be talking about fetal rights. Not just judgments, but even the government's submissions to court in some of these cases. The government of India's submission to courts in some of these cases talks about fetal rights, and that is something that is really concerning because that brings a whole host of ramifications to the legal scenario. And then finally, there is very subjective interpretation of the law based on value judgment. So some people are, some persons are seen as deserving of an abortion. So you're a good mother, you're in a marital relationship, or you're a sexual assault survivor. So in those cases, it is, there's a lot of sympathy factor, and therefore abortion is allowed. But in some other cases, you're seen as undeserving. If you're a married woman and you come somewhat late in pregnancy for various reasons, then the questions are asked as to what were you doing all these days. So there is a subjective interpretation of the law based on value judgment, and a lot of moralizing around this. So we are seeing a lot of this happening in more recently, both from within the courts and from the state's submission to the courts, which seem, all of it seem to be contributing to an increasingly hostile legal environment. So these are some of the emerging challenges that I wanted to speak about. Now, I want to just make the point that denial of abortion, not being able to access safe abortion services when faced with an unwanted pregnancy, is cruel and inhuman and is a violation of reproductive justice. Now, why do I say that? For example, if the person is a minor, denial of abortion to minors, again, this has happened several times in courts where because someone who's actually a child has reached out to the courts late in pregnancy to access abortion services, and the courts have denied this. This leads to significant physical and mental health consequences for the child who's a child herself and is forced to become a mother, and also to the child that she will give birth to. So a lot of physical and mental health consequences. Now, please note, like I said earlier, the majority of those seeking late abortions who actually end up in courts belong to vulnerable groups. They are structurally excluded, economically and socially vulnerable. So these vulnerable people who are not able to access safe abortion services early in pregnancy and are actually forced to seek services later on in pregnancy because of these various vulnerabilities that they have, are the most affected by by all of these legal ramifications. If a person is forced to become a mother, involuntary motherhood, in the face of an unwanted pregnancy, that denies the person, the woman, any some semblance of control over one's destiny as a human being, and therefore it is cruel and inhuman. And it imposes upon women from structurally excluded populations an extreme form of gender discrimination, where their life and well-being is seen to be subordinate to that of somebody else who's actually yet to be born. So the fetus is seen as, as having a higher kind of moral right than the person who's actually in the here and now and is in a vulnerable position. And that is why this is actually an issue of justice, of reproductive justice. Now, I want to end on a positive note. I again want to thank my colleagues in CommonHealth for this publication, and I would really urge all of you who are interested to go and look at this publication, which is on the CommonHealth website. This is actually a collection of stories, of real life stories of women who needed an abortion, were able to get an abortion, able to access a safe abortion service, and how it made a difference to their lives. Now, this includes stories of young women who have been able to, who faced with an unplanned, unwanted pregnancy, were able to access safe abortion and therefore continue with, their education and get on with, a better control over their lives itself. Of married couples who, when faced with an unwanted pregnancy, in kind of dire financial situations or economic situations, were able to access safe abortion, how that made a difference to their lives. Of women who started off with a wanted pregnancy, but their circumstances changed. For example, the husband passed away, and therefore they were in a position where they were not able to continue the pregnancy and therefore needed access to safe abortion and were able to get it. So these are stories where safe abortion is actually a lifeline. It ends up being life-saving, and it, like my colleagues say in this report, it's an act of restoring agency, reclaiming power over one's body, and then envisioning a future that is actually self-determined. So abortion is a lifeline and can be life-saving. It is a matter of reproductive justice. I will stop there and ask if there are any questions and reflections.
Thank you. Thank you. That was a very thorough talk. I think really gave us a sense of what the scenario of abortion is in India and vis-a-vis global movements and as well. Thank you, Dr. Subha Sri. That was very, very thought-provoking. I think for me, the main takeaway was, throughout the talk, you were talking about how it's the whole issue of abortion in India is not centered around the woman itself, right? It's doctors, it's the fetus, it's the judges, it's the activists, and so on. And the woman who should be at the center of it all is hardly visible. So I'm especially glad that you ended on a note of, centering women around what is a very essential sexual and reproductive health care service and how important it is for them to be able to access it. I encourage everyone to please send in some questions. We are running a little bit late, but if Dr. Subhashri is okay to take a few questions, we'll keep it going for a while then. I also want to thank also for putting the names of, references at the bottom of slides for people to look up sources for more details. I appreciate that. Ami Cycle asks, first, thanks you for an insightful session and asks if you could speak a little more about the intersection of caste, with other gender and other disadvantages in terms of access to services.
So thank you, Emmy, for that question. I used to work with a Dalit women's organization, RUSEC. I'm still associated with it in northern Tamil Nadu. And the stories we hear from Dalit women, not just related to access to abortion, but access to any medical service, is one of discrimination based on caste. And these are very subtle forms of discrimination, very overt forms of discrimination. I'm not getting into the details here. So this is overall, not just related to abortion service. Now, abortion becomes a particularly kind of, specific kind of example of this because even otherwise, there is a lot of judgmental approach to somebody who's seeking an abortion. There is a lot of shaming and stigmatizing. And caste adds, caste or, any form of kind of, access of vulnerability adds an additional layer of discrimination there. So definitely, these intersections of, so it is obviously very gendered. The whole gender angle is there, but these add additional intersectionalities to that. So yes, very much. So thank you very much for that question.
Archana asks, she's actually asked a specific question about the Lancet study, I think, that you cited at the front end of your talk. But some methodological questions. But I would like to broaden that question a little bit further to ask, I mean, there seems to be a dearth of good abortion data, abortion research. I mean, this study is based on data that's already a decade old. So can you tell us a little bit more or reflect a little bit more upon the state of abortion research in India and what kinds of research do we need to do? What kinds of data do we need to have access to in order to better understand the scenario?
So first of all, the whole, one of the biggest issues is the stigma around abortions and the need for confidentiality around abortions. So women or persons who need abortion actually prefer services that give them that confidentiality and privacy over, maybe even safety. So which is why women prefer to go to informal providers who will kind of keep it, confidential rather than go to public facilities where the service may actually be safer. Now that itself is a big kind of, problem with, the data on abortion. We had looked at in CommonHealth, some of my colleagues had looked at data on reporting of MTP. So the MTP Act actually requires that, that the MTPs that are performed in any facility should be reported to the district level authority. Now we looked at reporting, and they looked at specifically at reporting and found that many government facilities which had district level hospitals were reporting zero abortions when we knew that abortions were taking place. So they were providing the service but not actually kind of reporting. It could be the other way around also, with private facilities. So because of the nature, the gendered nature, and the need for confidentiality and the stigma around abortion itself, there is a lot of issues with reporting and data on abortion. So most of the estimates that we have are actually from small studies or modeling that kind of then extrapolates data from small studies to talk about numbers. Even this Lancet study, it is the largest kind of data kind of we have from a large study, so 4,000 facilities, and then a very interesting methodology. But it is still an estimate. We do not have data. Forget the number of abortions. We do not have data on deaths from abortions. So while we would say maternal deaths are something that are supposed to be reported, very often abortion deaths do not get reported, again because of the stigma around abortion itself. So that is something that is big, and unless we address some of these issues, it is going to be very difficult to get robust data on abortions. And this is not just a phenomenon in India, this is a global phenomenon. So I don't know if that kind of answers your question.
I mean, it answers it in so far as we're, I think, more aware of the challenges involved. But as you said, this is a tough research topic to explore due to the, as you said, there's a lot of moral and ethical and other sorts of concerns which don't necessarily arise in the course of regular health research or medical research, which makes it a challenging question. Archana asked another question, and I'm sure this is the question on a lot of people's minds as well, which is that what do you suggest? What strategies do you suggest to tackle the emerging concerns? It's very alarming to read about this rise of the anti-choice movement and the global gag rule that's keeps getting replaced and undone and so on. How does one tackle it? How does one approach this?
I really do not have answers to that, except to say that we are often kind of reacting and responding to these anti-choice movements, and maybe there needs to be a kind of a lot more proactive kind of push for reproductive choice or reproductive justice. I mean, many of these, especially the younger people, are on many of this is happening on social media, which some of us are clueless about. So one of the things that I was very surprised when my colleagues actually kind of were working on this and kind of showed us was Instagram reels that young people are putting up, saying I'm pro-life, I'm anti-abortion, I'm against abortion. Young people, could be school-going kids who are kind of putting up short Instagram reels about how they are anti-abortion. So I think we need to occupy some of these spaces proactively and have these conversations about choice and reproductive rights. It is not easy. It's not easy, and the concern is that younger people are actually they're targeting young people, and having very human rights based, not really human rights, but what from in the facade of having a human rights framework, or even science, saying that actually the fetus can feel pain, or the fetus can life starts early. So using some of these what they present as science but are not science actually. So there is a lot of need to actively counter these, and so maybe that is something that we really need to start talking about. The other thing is, and again, there is a small group that has been consistently working on this, is actually decriminalization of the law. We have a criminal law which is the crux of the problem. So the MTP Act, while it seems to be very liberal, is only an exception to the criminal law. And therefore, decriminalization is something that has been a demand. And again, CommonHealth has been working towards that. But again, it is not easy, especially in the larger scheme of things today, where human rights is actually a bad word, So that's the scenario that we are talking about. In such a situation, to talk about something as sensitive as sexual rights, reproductive rights, abortion. So there is also the danger that what we have currently is we may lose that, as it has happened in the United States. So there is a need to be strategic around it. But the answer is definitely decriminalization. Why should we have a criminal law It's a colonial era law, which has been long ago repealed in Britain itself. And we are continuing with that colonial legacy of, criminalizing abortion. And the the BNS, which is replaced the IPC, actually verbatim kind of has only the section numbers have changed, but verbatim the same laws are also there in the BNS. So when we have an opportunity to actually redo our criminal laws, as in this newly passed BNS, we have not addressed this issue of decriminalization.
Thank you. I think a couple of I think this speaks to one of the questions in the Q&A, which is about CSC. What role could CSC play? And I think, as you mentioned, if we were proactive about what young people are learning about sexuality and reproductive health, perhaps we could head off this problem at an earlier stage than before it becomes one of a legal and gets trapped in that legal medical scenario. Another person asks about, can you tell us a little bit about emergency contraceptive pills and access, and especially in rural India? And I actually do want to broaden that question a little bit again to, as you mentioned, the majority of terminations in India already in 2015 were largely medical, not surgical. So does the access to these pills, actually, emergency contraceptive and even otherwise, have they changed the landscape, do you think, in India?
Okay, so two things. So emergency contraceptive pills
I know those are two different
medical
things,
abortion pills.
but I guess I'm just trying to ask, broadly.
Sure. So just to clarify that these are two different things. So one is emergency contraception, which is if you have an act of unprotected intercourse and then want to prevent a pregnancy, then emergency contraceptives. Emergency contraceptives. So I come from Tamil. I'm sorry, my work has been in Tamil Nadu, and there is a lot of moral overtones about access to emergency contraception, and access to emergency contraception in Tamil Nadu, even within the public sector, is very difficult even today. It's patchy. Sometimes there is supply. Very often there is not supply in the public sector, and private pharmacies do not stock it. So access to emergency contraception is actually very difficult. Having said that, though, in many other states, emergency contraception is very readily available, both in the private sector and in the public sector. So access to emergency contraception is not so much of an issue as information around it is. So when to access it, where to access it, and then the whole stigma and thing of going to a provider and talking about having an unprotected intercourse and getting access to those. So that is an issue. Now, medical abortion pills are pills that are used to terminate once you have a pregnancy in place. So in the Indian law, it is allowed up to 9 weeks of pregnancy, 63 days, but international guidelines say that they can be safely used under medical supervision even at later gestations. But the law in India allows its use up till 63 days. That is 9 weeks of pregnancy. Now, your question about has medical abortion changed the landscape? Absolutely. What it has done is, one, we do not see as a gynecologist the kind of unsafe abortion procedures that we used to see earlier. I'm talking about, say, 3 decades ago or 4 decades ago. We do not see that kind of, because of so access to medical abortion pills has actually made the procedure much safer from a larger scheme of things, number one. Second, what it has done is, though the law says that you cannot, you can only get it based on the prescription of a doctor under the MTP Act. So you need a prescription to get a medical abortion pill. In many states, it is easily available over the counter, which is not within the purview of the law in the country. But what it has done, whether with prescription or over the counter, it has helped women or pregnant persons actually take control over the abortion process. So in a sense, self-manage their abortion. So you're able to get access to the pills, and then you're able to so that 81 that large proportion of medical abortions which are actually happening outside of health facilities may not necessarily be unsafe. If the medical abortion pills are used in a correct and consistent manner based on the protocols that are given, they can safely be used to self-manage an abortion if you have adequate support in case you have a problem. So in fact, WHO has a whole recommendation on care during abortions using medical abortions. So yes, medical abortion pills have definitely changed the landscape over the last few decades, and in a good way, where women seem to be able to get more control over their about access to abortion and also their abortion process itself because of the pills.
No, I think that's a heartening note to end on. I think there's a lot that's been challenging about abortion access in India over the last few decades, and I think this is one of the positive developments certainly that have occurred. I do urge attendees to read comments in the chat box. There's comments from Ami and from Archana and from Anirudh and others who talk about the realities of abortion access in India and the sort of the challenges to it from an activist point of view, from a legal, from a medical point of view. So I just want to urge people to read that, but I want to thank you so much for your time and the rich experience and knowledge that you have brought to this very tricky topic, I think, and for doing justice to it over the course of this colloquium. So many, many thanks from all of us here at the center for giving us this talk, for your time today.
Thank you very much, Abha. And I really hope we will be able to work together towards, addressing some of these issues. Thank you.
I hope so too. Thank you. Goodbye, everyone.